Thanks very much, and thank you for the invitation to speak here today. It's my pleasure. So my name's Katie Anders. I work for Oxford University in the clinical research unit in Ho Chi Minh City, Vietnam. And today I'd like to give you an update on what we know about the global distribution and the burden of dengue, and some of the key features of dengue epidemiology that we need to think about, and also some of the issues that we encounter when trying to quantify just how much dengue there is. So this is the outline of my talk. I'll go over the current estimates of the dengue disease burden, some of the drivers of dengue's emergence that we've seen over the past half century, and some of the characteristics of dengue distribution, including the spatial and temporal heterogeneity that's characteristic of dengue, the urban and rural distribution, the spectrum of disease severity, and some issues in estimating the dengue disease burden. And then finally, some of the work that's been done to translate these estimates of disease burden into estimates of economic cost. So I don't need this introductory slide for this audience. I'm sure you all know that dengue is an acute systemic vector-borne viral infection caused by 4 different serotypes, and with the main mosquito vector of Aedes aegypti. This figure shows the results of the most recent efforts to quantify the global burden of dengue and dengue risk and dengue disease. And it suggests that almost 4 billion people living in 128 countries are estimated to be at risk of local dengue virus transmission. And that's shown in this top panel here, which is based on a systematic review of all reports of dengue occurrence globally, including outbreak reports, research studies, reports of disease in return travellers, etc. And then from this top map, which is colouring from red is perfect evidence, essentially, of the presence of dengue, down to green being very good evidence of the absence of dengue, and the colours in between are where the evidence is not so certain. And from this map, these authors then generated a risk map of the probability of dengue occurrence at a 5 by 5 kilometre grid for the entire world, sort of modelling from this data and including what we know about environmental characteristics and demographic characteristics that are associated with dengue, to give estimates of dengue risk for every area of the world. And then using this, combined with data from cohort studies in different places, they modelled the estimates of the annual dengue infections globally and the proportion of those that are asymptomatic or inapparent infections and symptomatic infections, and came up with these estimates of almost 100 million clinically apparent infections each year, another almost 300 million asymptomatic infections. And these authors didn't estimate mortality, but previous estimates of mortality suggest in excess of 20,000 deaths due to dengue each year. So these estimates represent a substantial increase over the previous estimates of dengue burden, and as the previous speaker said, WHO has previously estimated around 50 to 100 million infections per year, and this is modelled estimates, so it's not recorded cases, but in part this increase is due to a substantial burden of dengue in Africa, which you can see here, and estimates of 15 million clinical cases and another 50 million inapparent infections in Africa, where there's previously been not a lot of data, and dengue is probably underestimated. But still we can see from this that 2/3 of the total clinical cases and infections occur in Asia, mostly in Southeast Asia. Yeah. So the current distribution and disease burden of dengue represents a dramatic increase from the situation 50 years ago. And this chart from WHO shows the number of case reports of dengue over the past 50 years in the blue bars, and the number of countries from which these reports came in the brown line. So you can see there's been an expansion both in the number of dengue cases reported and the geographic range, the geographic distribution from which those cases have come. And this map over here also illustrates this by showing that prior to 1960, in the yellow, outbreaks of dengue fever and dengue hemorrhagic fever were limited to areas of Southeast Asia and parts of South America. And in just 50 years, that's expanded to include South and Northern Asia, the majority of South and Central America, as well as countries of the Asia Pacific and Australia, although this is a bit misleading. We only see dengue up in that very northeastern corner. So what has caused this dramatic emergence of dengue across the tropical world in the past half century? Almost certainly it's a combination of factors, and we can think of these in terms of the various factors that shape the epidemiology of dengue, as shown here, and that's namely the human host, the mosquito vector that transmits dengue, the virus itself, and also the ecological and environmental context in which these factors interact. So just to think about each one of these in turn, the mosquito has the Aedes aegypti and the secondary vector Aedes albopictus have greatly expanded in their geographic range over this period, over this last half century. And a lot of that has been to do with the active transport of the vector via global transport routes. In terms of the human, increased connectivity and travel between humans has almost certainly contributed to dispersion of the viruses, especially with the advent of increased air travel, where people can be on the other side of the world in a matter of less than a day. Viremic humans can carry the viruses to areas where they previously hadn't been seen, as well as more local scale human movement that causes mixing of the viruses sort of at a local and regional scale. In terms of the virus, global spread of the viruses has been shown with leading to co-circulation of different dengue virus serotypes in one given area, which leads to an increased risk of secondary heterotypic infections and a higher risk of severe disease. There's also been several studies showing that clade replacement, especially within the dengue serotype 2, has occurred in Southeast Asia and also in parts of South America, where a fitter and probably more virulent virus has replaced previous dengue virus 2 clades. And then finally, changes in the ecology, in the environment in which all these things interact over the last half century has almost certainly contributed to dengue's increase, especially rapid urbanization in tropical regions such as this, such as Ho Chi Minh City and Thailand, leading to an increase in the environments that are favorable to the vectors and to, purple. Okay, I have rainbow presentation. This was not my design, but it's quite lovely. Okay, so now I'd like to spend a bit of time discussing some of the main characteristics of dengue epidemiology in endemic areas. Firstly, as I'm sure everyone knows, dengue displays strong temporal and spatial heterogeneity, which is to say there's a lot of variation in dengue incidence, both over time in a given location and also between locations in a given year. And the first temporal characteristic of dengue is that in endemic areas, at least, it's highly seasonal, and this is a predictable sort of temporal variation in that we know each year that dengue is going to rise when the rains come and fall at the end of the rainy seasons, although in places like Ho Chi Minh City, and I think here as well, it never really goes away in the intervening period. And this is just illustrated by this data from Ho Chi Minh City, where the black bar is monthly dengue cases, or weekly dengue cases actually, and the blue is the rains, and this is the median temperature. And quite predictably, as the rains come every year, at a lag of a couple of, or a month or so, dengue cases rise. And so these annual cycles that we're familiar with dengue are driven by annual climate, by climate variables. There's a second aspect to the temporal heterogeneity in dengue, which is the interannual variation in incidence. And this is less predictable. So this is illustrated here in several countries that we see. This is southern Vietnam with cases per year varying quite a lot. This is data from Thailand, data from mainland China. All show this interannual variation in dengue incidence. And several studies have looked for patterns or periodicities in these interannual differences in incidence. And in some locations, but far from all, regular multi-annual cycles have been shown to occur, often at a 2 to 3 year interval. For example, here in 3 provinces in southern Vietnam, all you need to know about these sorts of graphs is that on the y-axis, this is the periods here from 1 year periodic cycle, 2 year, 3 year, 4 year, and this is a 10-year time frame that shows that in these 3 provinces at least, the 2 to 3 year periodic cycle was actually stronger than the annual signal that you saw that's due to the climate factors that we just discussed. And similarly, from this study in Thailand, this is all the provinces in Thailand and dengue incidence over a number of years. And you can see that there's around 3 years, there's increase in dengue incidence, which is quite incredibly sort of synchronous across all of Thailand. And these multi-annual cycles are probably driven rather than by climatic variables, although some people have suggested that things like El Nino and macro climate things contribute to this. It's probably largely driven by things like local population immunity and serotype changes. So we've talked about temporal variation, now talking about spatial variation in dengue incidence. And this can be called spatial dependence, which means that the dengue incidence in one area is dependent on spatial relationship. It's more similar to things close by than it is to places further away. And this can be seen at different spatial scales, from an intermediate sort of district or province level scale down to community, finer scale of communities and households. And first I'll show you some work that we've done looking at this on the intermediate spatial scale using dengue surveillance data from southern Vietnam. These 19 provinces of southern Vietnam down here. This was in collaboration with the Pasteur Institute, Ho Chi Minh City, and included a 10-year monthly dengue time series aggregated by district. There are 159 districts grouped into 19 provinces, 10-year time frame. Dengue surveillance data in Vietnam includes only hospitalised cases based on a clinical case definition in both adults and children. So within this aggregate time series that includes the whole region, you can see some interannual variation. But what's obscured here is that when you break this down to firstly a province level, so this figure shows the 19 different provinces up the side, the 10 years across the bottom, and the colours represent for each province their highest incidence years and their lowest incidence years in the lightest colours. And you can see that different provinces, and when we do this, the same thing, but this is now 159 districts up the side, there's a lot of variation in which, in a given year, which provinces are experiencing high incidence and low incidence years, and it's not very synchronous even across this area of southern Vietnam. So that's what I'm saying here. Different provinces and districts have their outbreaks or high incidence years at different times. And when we look further at this data, we found also that the timing of the onset of dengue epidemics in these different districts and provinces varied. And we looked at whether there was a spatial pattern to this, that is, districts that are closer together, more similar in terms of when their epidemics occur and how big their epidemics are compared to districts that are further away from each other. And we found that that's true, that districts that are, so this is how close any two given districts are to each other, increasing in distance, and how highly correlated they are in terms of the timing of their dengue epidemics and the size of their dengue epidemics. And we found that out to sort of 50 kilometres or 100 kilometres, that there is a spatial relationship. So closer proximity makes the dengue epidemics more similar. But beyond 50 or 100 kilometres, that falls apart. So then beyond that, doesn't matter how far you go, they're no more or less likely to be similar in their dengue dynamics. And the relevance of this is that it might give us insights into what's driving dengue epidemics at this local sort of scale. And we could think about things like microclimate, which is quite difficult to measure because for Vietnam at least, climate data is on a province level. It's hard to measure things at a more local level. Local population immunity, maybe local serotype changes, and possibly mixing of human movement within this sort of 50 to 100 kilometre range. So there've also been studies looking at clustering of dengue at a much finer spatial scale of the household, and these three studies, first one from Thailand in a rural area in Kampang Phet in Thailand, and then one in Jakarta and one in Nicaragua, have shown, so this Thai study in particular that used an index cluster design, which means you take a diagnosed dengue case, you go to their house, you enrol people, their household members and their neighbours, and you follow them up for a couple of weeks and look for secondary dengue cases. And in this study, at least, they had control clusters where they had non-dengue cases, and they could compare how clustered dengue was in the positive clusters to the negative clusters. And they found a marked clustering of dengue infection risk, with 16% of 16% of participants in dengue case clusters having dengue infection during the study period, compared to only 1% in control clusters. There's also a suggestion of household clustering in the Indonesian and the Nicaraguan study, although they didn't have control clusters. So although they showed secondary cases around the case cluster, they couldn't compare that to what was happening in the community at large. And in the Thai cluster study, the authors looked in even closer detail at the risk of dengue infection both in children and in mosquitoes that they caught in the home as a function of how close they were to that index case. And they showed that at an even finer scale within these clusters, there was an increased risk of dengue. This is distance from the index, increasing distance from the index case house, and the risk of dengue infection in the children or in the mosquitoes. And they showed a real spatial dependence, where those living closest to the index case had a higher risk that waned as you moved further away from the index case household. So this evidence for households as a focus for dengue virus transmission is the basis for strategies used in lots of dengue endemic countries that target the households of known dengue cases with vector control interventions and spraying. And that seems to make sense. But there's still not a lot of evidence from highly urban settings like Jakarta or Ho Chi Minh City to what extent this holds true, where you've got high human density and highly mobile populations who might be sort of mixing and generalizing the risk of dengue infection more than in these rural settings. So people have got increasingly interested in how human movement might impact patterns in dengue transmission. And this research group in Iquitos in Peru excuse me, examined this by looking at what they called the activity space of dengue cases in the 2 weeks prior to the onset of their illness. And this means, basically, don't worry about the diagram, but they asked cases who were diagnosed where they had been in the last 2 weeks. Then they went to just which houses they had visited in the last 2 weeks, and they went to all those houses and followed up people there to look for other dengue cases. So it's similar to an index cluster study, except that instead of the cluster being geographically centred around the household, it could be any geographic range. It depends on where that case went in the previous 2 weeks. And quite remarkably, they showed that in the clusters, which are now activity space of cases, there was a much higher attack rate of other dengue cases compared to the places where non-dengue cases had been. And so the authors conclude from this is that human movement, at least in this setting, small-scale human movement of people within the community might be a big contributor to dengue virus transmission and the patterns of dengue that they see. To just conclude about this spatial and temporal heterogeneity, why this is important, as Dr. Halstead said earlier, to get a sense that the temporal variation and the spatial variation means that to get a sense of dengue transmission and dengue burden in a given location, we need to look over quite a number of years because there's so much variation year to year. And also when we're looking at the dengue burden within a given country or region, by looking at too high a level, we're obscuring a lot of the local differences in dengue transmission. So it's good to look at as low a spatial scale as possible. Next, I'll just talk a bit about the urban and rural distribution of dengue. So dengue's historically been thought of as an urban disease, still is thought of as an urban disease, and this makes sense due to the high density of susceptible individuals, inadequate housing, perhaps inadequate water, and availability of favourable breeding sites for vectors in close proximity to humans. But there's increasing evidence of high incidence of dengue also in rural areas of endemic countries. And I'll just show you a few of those here. Firstly, this study in Cambodia looked at dengue incidence rates at, in different districts and found that in rural areas in this varied year to year, but in rural areas in some years at least, they saw as high or higher incidence rates as in the urban areas. Also, in a study in central Vietnam, they found a similar thing, that the rate ratio, the risk of dengue, was higher in rural than urban areas. And in that data set I just showed you from southern Vietnam, we also looked at correlating the mean annual dengue incidence over this 10-year time period against a figure that's provided in census data about the proportion of people in a given district that live in rural versus urban areas. And this is the more rural and this is the more urban. These are almost all Ho Chi Minh City districts. And there was no correlation in that the urban districts had no higher dengue incidence than the rural districts. Another consideration when we're talking about measuring the dengue disease burden is the spectrum of clinical outcomes that you can get from a dengue virus infection. And this, as everyone knows, ranges from severe dengue, which will normally be picked up by hospitalized cases, uncomplicated dengue who might present, some of which will present to health facilities and some of which won't and will just be in the community, and a variable but quite substantial proportion of infections that are asymptomatic. And different data sources, depending on which data source you use, you will capture different subsets of this overall sort of dengue infection burden. Routine dengue surveillance systems will only detect cases that present to health facilities, obviously, and unless they have sentinel systems in the community, but most don't. And in many countries, including Vietnam, this only captures this top hospitalized proportion of dengue cases. Some may have outpatient surveillance as well. Active case detection by, say, acute febrile illness surveillance will pick up a greater proportion of the overall burden by finding at least some of these unreported, clinically apparent dengue cases. And finally, to capture the full picture of dengue virus transmission, including inapparent infections, requires a much more resource-intensive design with serial longitudinal blood samples collected from cohorts. And there's fortunately several of these cohorts that have been running in different countries for many years to provide this sort of data. But this is just to emphasize that with the routine data available to us, we're only sort of seeing the tip of the iceberg of dengue. And this is just summarized here in terms of when we're using data from national dengue surveillance systems, which is the most readily available, there's some important limitations need to be considered. It's usually both in terms of specificity, so it's a clinical case definition usually, which will include some who aren't really dengue. It's often hospitalised cases, laboratory diagnosis only in a small proportion. But this data is useful for measuring long-term trends in an area. And there's been several attempts made to quantify the degree of underestimation of the dengue disease burden when you're using national surveillance data. And this has come up with estimates in the range of a factor of 4 to 29 that you need to multiply up surveillance numbers. That's from Cambodia, a similar sort of range from Nicaragua. And then this study looked at, I think, 8 or 12 countries in Southeast Asia and came up with an overall expansion factor of 7.6, but this ranged between the different countries from around 4 to around 19. I'm going to skip that in the interest of time. I'll just go back one, actually. So we've talked about measuring clinical cases, which are obviously a relevant endpoint when we want to know about the burden of dengue for health systems. And they're also used as an endpoint for vaccine studies. But if we want to get a picture of the overall transmission intensity of dengue, we need to be thinking about measuring dengue virus infections. And as we've said, that's hard to do and very resource intensive. But at least it can be done sort of cross-sectionally with serological surveys at different times. But we also run into trouble in terms of what to measure if we do have these longitudinal serum samples. Unlike malaria, where you can look at parasite prevalence rates to translate that into a measure of transmission intensity, the viremia in dengue is very short-lived, so there's no point looking cross-sectionally for virus. Serological assays for dengue IgG are cross-reactive with other flaviviruses where these co-circulate, and they only indicate lifetime exposure, so they're sort of useful in younger age groups where you're going from naive to infected, but not really beyond that. The best that have already been mentioned by Dr. Halstead are probably the neutralization assays that can give you information about serotype-specific antibodies, but these are costly and resource intensive and are really only easily interpretable for the first and second infections. Beyond that, it gets messy with the cross-reactive antibody. And finally, there's been some suggestions to use IgM measured cross-sectionally as an indicator of recent dengue virus infection, but this is also problematic because the duration at which IgM hangs around is variable and differs between first and subsequent infections. And there's also issues of specificity, especially in places where you're, where you also have malaria. So as you can see, it's difficult to know what we can measure. In terms of the proportion of the overall transmission intensity that you see when you look just at symptomatic cases, there have been several studies looking at the ratio of symptomatic to asymptomatic infections in different populations. The first of these is from Thailand, again from the Campaign PET study, which used two different methods. Firstly, when they were finding their clinical cases based on school absenteeism, they came up with these estimates of the vast majority, of almost 60% to 80% of dengue virus infections being inapparent. But then interestingly, when they combined this with a different study design, the index cluster study design that I just talked about, where you're actively looking for cases around an index case, they found that actually the proportion who were truly inapparent was much lower than previously thought, only around 20%. So there's a lot of cases who are mildly symptomatic, maybe even including febrile cases, but who are continuing to go to school, go about their daily business, so who are missed in these estimates. And they also looked at, because there was a lot of year-to-year variation in this proportion of inapparent infections, they looked at what factors might be associated with that. And the only thing that they found in this study was that a higher overall incidence in a given year was associated with more symptomatic cases, but then conversely, a higher incidence in a previous year seemed to have some sort of cross-protection, whereas the following year you had a lower proportion of symptomatic cases. A second lot of information comes from the Nicaraguan study, where they had a pediatric cohort study where people presented to health clinics with dengue, and they found, interestingly, that the proportion of cases or infections that were symptomatic was similar across first infections, secondary infections, and even post-secondary infections. And I think, as Scott mentioned earlier, they showed that symptomatic secondary infections occurred at a longer time interval after than inapparent secondary infections. So that reflects this cross-protection, duration of cross-protection that Scott talked about earlier. The last, my time's up. I've got just a couple of slides on economic burden, which I'll go through very quickly, if that's okay, or shall I stop? Yeah, will I go through?
Do they have a lot of slides?
No, I will flip through these actually and just go to the summary. All these are saying is that there's efforts to translate this disease burden into estimates of economic burden, which have some problems in terms of measuring the cost of dengue illness, because this is very different country to country in the way that's been done. Skip through this. Just my summary slide. So, in summary, as we know, the geographic range and burden of dengue is expanding, and recent estimates of the dengue burden have represent an improvement, in part because they account for the uncertainty in measuring this in different areas and point to areas where more data is needed to refine those estimates to more precise figures. Dengue incidence is temporally and spatially heterogeneous, with clustering occurring both at medium sort of regional scales and fine spatial scales. There's increasing evidence that dengue is a public health problem in rural as well as urban areas in endemic countries, and the appropriate metric or measure for measuring dengue depends on the purpose, and for some things we could consider clinical case burden, whereas for other things transmission intensity measured by infections rather than disease might be a more relevant measure. And then finally, which I skipped over, these disease burden estimates translate into quite a considerable figures for the economic burden of dengue, and show that there's potential for large economic benefits from preventive interventions like vaccines or other novel interventions. Thank you.